Hello and welcome to Season 2, Episode 30 of the Physician Assistant Exam Review Podcast. This episode, we're going to start endocrinology and begin with the thyroid. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review. You can always get all the notes over at physicianassistantexamreview.com. All that stuff's over on the website. It's totally searchable. There's up in the right-hand corner is a nice little search bar thingy majig that I had put in not too long ago, which really works great. There's also the blueprint tab in the upper right-hand corner, which will bring you to a nice list. And I'm trying to keep it a little bit more organized these days as I go through Season 2, a nice list of the blueprint content. One of the sections that I realized was pretty bad and was endocrine. I went back through and it looked like it was the very first thing I ever did was endocrine. In fact, the first couple things I covered, Cushing's, for example, and Addison's, I think I didn't even do a podcast for, and I sort of just put some notes together and put it out there. And then I went back and did some podcasts covering it, but I listened to them and they were awful. So hopefully these are a little bit better today than they were when I very first started out over 100 episodes ago. But all that stuff's out there. I'm slowly taking down the old stuff as I cover it. I don't think you can get any more of Season 1 from cardiology anymore or OB because we've covered all that in Season 2. So all of those, I'm trying to make myself look better by removing the episodes that were so bad so long ago. Hopefully, like I said, hopefully these are improved a little bit. So this week we're going to start with endocrine. That's one section that I've been getting some questions about, again, because the old section was old and some of the episodes were falling out the back of the podcast feed because only so many episodes stay in the feed. So those are ones that were starting to disappear. So we're going to recover that or begin covering that a little bit better in a little bit more detail for Season 2. And we're going to begin with the thyroid. That's, we'll talk about it as we move forward. So let's start off and jump right into it in this episode with our priming questions. Number 1, where is TSH created? Thyroid stimulating hormone. Where is it created? If you haven't done this stuff in a long time, don't expect to know these off the top of your head. Where is TSH created? Remember, we're just doing these to get you ready for the show. We're going to cover all the information in the show, but it helps to get the information to stick. It helps to get you to remember things. One, if we repeat them, but two, if you use your brain, if you actually try to work through some of these, even if you get them wrong, even if you don't know them, stop and think about the answers. It will help you to retain the information moving forward. So where is thyroid stimulating hormone created? In the anterior, I didn't want to tell you yet. Well, I'll get to that later. What is the most common cause of hyperthyroidism? What is the most common cause of hyperthyroidism? Most common cause of hyperthyroidism. Next, exophthalmos should make you think of what diagnosis? We're going to be in trouble because I have to say that a few times this show. Exophthalmos should make you think of what diagnosis? All right, and only 3 primary questions for today, just those 3. So endocrine's a little funny because it's kind of circular. I spent a long time putting these notes together because I put a lot of the notes together for the whole section of endocrine because, like I said, it just goes around in a circle. Obviously, you have different organs, different hormones, turning on different hormones, and then turning on different organs. So it's hard to talk about one without talking about the other and without having covered some things first and then some things second. Even in this episode, specifically, we're going to start covering the thyroid. We're not going to finish the thyroid. We'll do the first half, which is going to be hyper and hypothyroid. I wanted to talk about thyroiditis because it's going to come up in this discussion. And I started to put that first, but then I realized it can't be first. And it's like I said, it's not like a lot of other systems that are straight. It's a straight line from beginning to end. Maybe one or two other issues, but with endocrine, it's a big circle. So it's hard to know it until you know it. So my point is, you should probably go through these a couple of times and make sure that you really understand the whole system. And once you finish these episodes, as we go through endocrine, maybe these are ones I would start at this episode and go through a second time just to make sure everything's nice and clear for you. I think that's, especially with endocrine, I think that makes a lot of sense. The good news about endocrine is there's only a handful of things that you need to know about, right? There's only a couple of organs and what they do that we need to know about, right? So we cover the thyroid, we cover the parathyroid, we'll cover the pituitary, we'll cover the adrenal glands. That's really the bulk of what we're going to be discussing. We will talk a little bit about diabetes, and then we'll talk a little bit about lipid disorders because that's in the blueprint, but it's not quite so overwhelming if you break it down into those categories and you learn one at a time. Like I said, they do sort of overlap and return on each other, but if you learn one at a time, it's less intimidating. It's not quite such a big deal. So we're going to start with the thyroid, and we're going to knock that one out at this episode, and then in the next one, we'll get that done, and probably the parathyroid in one, and we'll move forward from there. So anyway, let's go ahead and get started with disorders of the thyroid. We're going to start with the hormones we need to know about. Again, this is going to be, hopefully you know a little bit about this stuff. If you don't, you may have to get the whole picture once we're done with all of these episodes on endocrine. So TSH is thyroid stimulating hormone, and it is created and secreted by the anterior pituitary, which I gave away a little earlier, created and secreted by the anterior pituitary. T4 is thyroxine. T3 is triiodothyronine. I can't remember how you pronounce that. I apologize. And then something to talk about is moving forward. We're going to talk about primary disease and secondary disease, especially here at the thyroid. Primary disease is disease in the thyroid. Secondary is caused by disease in the hypothalamus or the pituitary. So we're going to talk about things where either the thyroid's not working because the thyroid's not working, or the thyroid's putting out too much T4 because the pituitary is telling it to. Those are our differences there. So it's either the thyroid has a problem or something outside that's working on the thyroid has a problem. And that's the difference between primary and secondary in this case. Hyperthyroidism is where we're going to begin our discussion. It's an elevated levels of free T4 and T3. Something just a side note, amiodarone may cause thyrotoxicosis. So just amiodarone is will mimic some of the things that the thyroid does. So pay attention to that drug in particular throughout this section. Causes of hyperthyroidism. Graves' disease is the most common hyperthyroidism, accounting for between 50 and 80% of cases, and it's an autoimmune disease. The weird thing about Graves' disease is the body creates antibodies that bond to the receptor for thyroid stimulating hormone, and that's not uncommon. There are certain antibodies that the body will create in an autoimmune situation which will attack certain areas, right? We know that. The weird thing here is that it's a stimulant. Most of these situations, it doesn't stimulate the organ to do something. It actually just blocks all those receptors. So in Graves' disease, the body creates antibodies that bind to the receptor for TSH and stimulate production of T4 and T3. So we get hyperthyroidism, right? So we get tons of T4 and T3 production due to these antibodies that are created. For clinical presentation, the thyroid may have a goiter or palpable thyroid nodule, and it may be tender. For this section, I'm just going to kind of combine clinical presentation and physical exam findings. It didn't make sense to separate them all out and have these huge, tremendous lists where I doubled a lot of these things. So I just want you to be aware. I'm handling this a little bit differently than the rest of the sections. For the eyes, they get a very specific stare, lid lag with a downward gaze. That's eyelid lag with a downward gaze. You can get upper eyelid retraction, and then exophthalmos. So the upper eyelid retraction does also make the eyes look like they're bulging out a little bit, but the exophthalmos is really the key there. And then you can get diplopia. That comes from the muscles around the eyes having problems secondary to the thyroid issues. For the heart, you can get tachycardia, you can get AFib, you can get palpitations, you can get chest pain. Skin, very fine hair on the skin. It becomes warm and moist. You can get onycholysis, which is the breakdown of the nail beds. Pretibial myxedema, which is you can get some blistering on the front of the tibia. Mental changes, irritability, nervousness. You get that. Hold on a second. And then there's a whole list of other things. There's tons of possible outcomes here because the thyroid affects pretty much all kinds of things in the body. You can get fatigue, you get heat intolerance, sweating, changes in weight, increase in appetite, loose stool, frequent urination, muscle cramps, changes in menstruation, and then also a fine resting tremor and hyperreflexia and insomnia. So you picture this person as somebody with their eyes bulging out, with moist, sweaty skin. They're irritable, they're nervous, they're twitchy. They've got heat intolerance. They're on edge. They've got hyperreflexia. That's sort of how I picture this person in my head, so I can keep it straight from hypothyroiditis or hypothyroidism, and then you have this image of this person who's just, like I said, just kind of twitchy and can't sleep and had too much coffee, basically. It's kind of how I think of it. They get tachycardia, they get palpitations and chest pains, and that helps me to keep this person in my head and get these questions right, because all of them there's this huge long list of symptoms, right? So you can't just throw out there, you have a person with palpitations comes into the office, because that's not enough to get the question right. They're going to have to include things like the stare, or the eyelid lag with downward gaze, or heat intolerance always seems to be one that is really easy. I don't know that you're going to be that fortunate to get that one, but that seems like one of the hallmarks here for a test question on hyperthyroidism. Blood work here is going to be very important if you're trying to work this up. So thyroid stimulating hormone is usually decreased, TSH. If you think about it, if we have an overproduction of T4 and T3, because of the way the system works, the thyroid stimulating hormone, the pituitary, will stop producing TSH. The body will try to stop production of T4 by not producing as much TSH. The problem is most of these issues occur within the thyroid itself, so it isn't actually going to help to drop that TSH, right? Or if we have something like Graves' disease, we'll talk about in more detail later, if that's an antibody that's attacking the thyroid and causing it to be stimulated, well, dropping our thyroid stimulating hormone isn't going to affect the thyroid because we have all that antibody stimulating it. So usually TSH will be decreased, but not all the time, right? In a case where you have a problem secondary to a pituitary tumor and it's creating too much TSH, right, that will create a situation where then the thyroid gets super stimulated also. But that's just much more rare. It's much less common than the other reasons for hyperthyroidism. So usually TSH will be decreased and you'll get an elevated T4 and T3. You can get an elevated SED rate, and then you may also get a TSH receptor antibody elevated, like in Graves' disease, what we were talking about. A couple other studies you could get would be a radioactive iodine uptake scan. So it will be taking up more iodine in this case, if it's active, if it's a hyperthyroid, and then an ultrasound you'll show an increased blood flow to the thyroid. Treatment here, you're going to start with beta blockers to decrease the heart rate and take care of some of those jittery symptoms. Propranolol it seems to be the number one thing mentioned here, although most of the things that I was going through said, although historically propranolol is the number one drug, it may not be the best one. Atenolol and metoprolol fall in right here as well. So you're going to use a beta blocker. You're going to want to bring that heart rate down, and it'll take care of a lot of those symptoms. To actually combat the hyperthyroid, you're going to use methimazole, and this one's a tough one. PTU, which is propylthiouracil. So you can all get a good laugh at how I pronounce that one. But that's PTU, which is used to inhibit production of T3 and conversion to T4. So it helps to actually stop the process of making thyroid hormone, okay? So that's going to be one that actually controls the situation. The beta blocker just stops the symptoms, right? These two are going to actually break the cycle. These can either be used as treatment in patients if they don't have if it's not a huge problem, or it can be used as treatment if they can't undergo surgery or iodine ablation. And then the next step is going to be, it can be used to prepare patients for surgery, or for surgery to kind of shrink that thyroid down a little bit. You can do radioactive iodine ablation. You can do surgical removal of the thyroid or of the nodule, depending on what's causing the problem. And then we're going to move on to a thyroid storm. For a thyroid storm, the important thing to understand here, two things. One is it's very rare, and two is it's a life-threatening emergency, all right? This is someone who has to be treated immediately. This is a very dangerous situation. This is typically an untreated patient with Graves' disease or a multinodular goiter. This isn't, like I said, this is pretty rare right now, but it's something you have to be aware of because it's a life-threatening emergency. Risk factors for this. So what brings this on? This is someone who may have a little bit of a problem, but then has untreated Graves' disease, let's say, but then on top of that has an infection, which causes a lot of stress to the body, or has surgery, or has some sort of trauma. And then preeclampsia is another one that'll kick this over the edge. But you think about this as the person has hyperthyroid, and then there's sort of an initiating factor that pushes them over the edge and creates this thyroid storm. Clinical presentation is basically all the things from hyperthyroid, but you're going to include a fever, severe tachycardia, vomiting, diarrhea, dehydration, muscle weakness, and confusion. Blood work, again, TSH is usually decreased. We're going to have elevated T3 and T4. And then you're also going to get your ultrasounds, if possible, and a BMP, because you're going to want to make sure that their electrolytes are in good, look okay, so we can correct that if that's going to be a problem. Treatment is going to be pretty much the same as, or very similar to what we were doing earlier, just more aggressive. So you're going to do the PTU and iodine combined. You're going to do propranolol. You're going to do IV fluids to correct if there's a dehydration or their fluid problems, a cooling blanket, and then lastly, corticosteroids to decrease inflammation, both throughout the body and within the thyroid. So it's just going to be a much more aggressive treatment. It's going to be higher doses, IV, and treated in the hospital. Next, we have hypothyroidism, so a decrease in T4 and T3. Causes here are going to be thyroiditis, which is why I wanted to cover it before we got here, but it didn't make sense. Another problem could be the patient has no thyroid, meaning usually that it was taken out through iodine ablation or surgical removal of the thyroid. So we had someone who had hyperthyroid, and to treat it, we took out their thyroid. So now they're hypothyroid, right? They don't make any of the hormones from the thyroid. This can also be a congenital issue. And then some medications can cause this. So something to be aware of if you're using these. So amiodarone, which is structurally similar to thyroxine, can cause hypothyroidism. Lithium is another one, which is used to treat depression or bipolar. It can cause hypothyroidism. And then PTU and methimazole. These are obviously can mimic a hypothyroidism by decreasing the production of T3 and T4. All right, clinical presentation here. These are sort of the opposite. This picture in your head needs to be the opposite of the person with hyperthyroidism, right? So that person was a jittery, you're sweaty, twitchy, heat intolerance, can't sleep, a little bit of a tremor, eyes bulging out. That was our sort of a caffeinated person, was sort of how we thought of a person with hyperthyroid. Our hypothyroid person is going to be just very much the opposite. So they have cold intolerance. They have slow speech. They have a hoarse voice. Those are sort of two nice hallmarks for you. They can get paresthesias. They have kind of a puffy face, fatigue, changes in menstrual cycle, typically heavier, but sometimes it can also cause secondary amenorrhea. They have pale, cool, dry skin, thin, brittle nails and hair. They have a poor memory. They can have depression, psychosis, and dementia. They get muscle stiffness and anorexia. They get constipation, where we had loose stool earlier, now we have constipation. They can get some weight gain. A lot of that has to do with fluid retention. And so then they also have edema. Instead of tachycardia, they have bradycardia, and they're hyporeflexia as opposed to hyperreflexia. So it's just the opposite of that person with hyperthyroidism. Labs and studies, the blood work here, TSH is usually elevated in primary hypothyroidism because the pituitary is trying to get that thyroid to work. So think about this. If the TSH comes from the pituitary and it's saying there's not enough T4 and T3 out there, so let's increase that so it starts to pump out more TSH. Well, if there's no thyroid, let's say we just removed it, there's no thyroid, that TSH is not going to get acted on by anything. It's not going to create more T4. So since the T4 levels aren't growing up, the pituitary is going to keep putting out more TSH to try to get more T4, but it's never going to happen because there is no thyroid. So it's just going to keep elevating TSH. So our blood work in hypothyroidism is usually going to be an elevated TSH. Again, that's not if there's a problem with the pituitary. If there's a tumor or something, or we take out the pituitary, just let's pretend, if we take out the pituitary, then there is no TSH and there is no T4, right? We don't make a lot of T4 if there's no TSH out there floating around. So we get hypothyroidism even with a low TSH, but normally, most of the time, TSH is going to be elevated. You may have to go back through and listen to that, or go back through some materials to make that click in your head. It just has to do with the positive and negative feedback cycles all throughout the endocrine system. At the end of all this, we'll try to wrap it all up into a nice, neat little package, because I know it can be hard to picture all that in your head. Also, CBC may show anemia. It'll be normocytic and normochromic, usually not that low, but a little low. And then for a BMP, you can get some low sodium. Treatment for hypothyroidism is thyroid hormone replacement. So we use most commonly that I see is levothyroxine. It's a synthetic T4. Patients are started on the lowest possible dose and then slowly moved up while monitoring their symptoms and their TSH levels. Once the dose is set, it takes yearly checks to make sure that all the levels are correct. And treatment here is forever, right? So if we take out your thyroid, you're going to need levothyroxine for the rest of your life to replace that hormone, right? It doesn't get better, it doesn't go away. And then you're going to monitor for symptoms of hyperthyroidism in these patients because you don't want to be overdosing them. Myxedema is the clinical mirror of thyroid storm. It's extremely severe hypothyroid, and it's a true life-threatening emergency, just like thyroid storm is on the other end of the spectrum. So our patients here come in with all of the issues from hypothyroidism, but they also have more severe mental changes. They can wind up with confusion and go into comas, convulsions, hypotension, hypothermia, hypoventilation. They can get rhabdomyolysis and acute kidney damage and hyponatremia. Treatment is going to be, again, in this case, it's our same treatments, but just more aggressive. So it's IV levothyroxine. You may have to intubate these people and then slowly warm them up if they're too cold. So that wraps up our discussion of the thyroid for today. We'll move into a little bit more next week, or next time, and we'll cover thyroiditis and cancers of the thyroid, different types there. I think that's really going to be valuable for your exam. This section is so easy to ask test questions on, the hyperthyroid stuff. It's so easy to ask test questions on. I strongly recommend that you go through it a couple of times. Again, we'll cover a little bit more of it next time. But it's something you really need to have a good handle on because you're going to get questions on it because of the nature of all these symptoms and the way that they go together. But I think if you picture them in your head, both the two opposite people, the hyper and the hypothyroid person, and you can hold that picture in your head, they're really not that hard to get right. You have to know a couple of treatments, but that's really it. It's not super complicated to parse these questions out. So let's jump into one now. I want to talk a little bit for our study tip this week. I want to talk a little bit about something I called question stacking, which is something I spoke about in the emails, which I strongly recommend you sign up for because I send out tons of tips and things that'll help you in techniques and general help in the emails, which go out almost every single day. When I talk about question stacking, what I talk about is the idea that you get a couple different kinds of questions on your exam. You get super straightforward, easy questions, right? Like that just aren't that complicated. And then they take those, and then the harder questions, the ones that look like paragraphs long, are really just those simple, easy questions stacked on top of each other. So they take one easy question, straightforward, one sentence, what's the answer? Then they combine that with another one, and then another one, and then another one, and it becomes this big, long paragraph that looks terrifying and scary. But the reality is, if you can break them down into their component parts, they're not that scary and they're not that hard. But you look at the questions and you get a little bit overwhelmed and you're not sure how to handle them. So let's run through one example here today. This is a 38-year-old female presents with palpitations, sweating, and heat intolerance for the last 3 months. She's also noticed that she's losing weight unintentionally and she can't sleep. She's terrified she has cancer. On physical exam, you notice a large, non-tender mass in her anterior throat. You reassure her and ask her to get some basic lab work done. After seeing her blood work, you decide to put her start her on some medication. Which would be the first medicine you would start? Right, so that's always the annoying question because they say, what should be the first medicine you should start? And then they give you a list of things that you want to give. And that's the painful part. So anyway, we have this big, long question, and you're listening, driving in your car or jogging, and it's hard to remember. So I'm going to run through it one more time. A 38-year-old female presents with palpitations, sweating, and heat intolerance times 3 months. She's also noticed that she's losing weight unintentionally, and she can't sleep. She's terrified she has cancer. On physical exam, you notice a large, non-tender mass in her anterior throat. You reassure her and ask her to get some basic lab work done. After seeing her blood work, you decide to start her on some medication. Which would be the best medicine to start her on? Now, I get the question's a little bit vague. I didn't sit and put all the details in it, but you get the idea. The medicine choices are levothyroxine, indomethacin, digoxin, and PTU. So you have to break this down into its component parts, right? So most of you can do that pretty quickly on this question because we just covered the information. But 6 months from now, if you hadn't just done it, this question would seem really hard. A large non-tender mass in a young woman's throat, which is linked to palpitation, sweating, and heat intolerance, is probably hyperthyroid, right? We can all see that considering we just covered the material. It's not hypothyroid, and it's a mass in her anterior throat. She's sweaty, has palpitations, it's probably hyperthyroid. Well, what's the most common cause of hyperthyroid? We said earlier is Graves' disease, right? So then it's asking what are our best medication to start. Well, what were our treatments for hyperthyroid disease or Graves' disease? We talked about beta blockers, and we talked about methimazole and PTU. And then we talked about doing surgery, right? Those are basically what we were going to do. So we have propranolol, atenolol, metoprolol, and then we have methimazole and PTU. So we look at our list here, and levothyroxine is for hypothyroid, right? That's replacing thyroid. We're not going to do that. Indomethacin, we're not going to do that. Digoxin, we're not going to do that. And then we have PTU. So the only one that makes any sense in this case is PTU. So the question isn't particularly difficult. It's breaking it down into those sub-questions to understand what we're actually asking, what it's actually getting at, and then isolating the correct answer. So this is what I call, like I said, what I call question stacking, or you take some simple questions. So if I just ask you the question, a 38-year-old female with palpitations, sweating, and heat intolerance times 3 months, you sort of start to gather a picture in your head. If you have a young woman with heat intolerance, right, that sort of starts to jump out at you that we're talking about hyperthyroidism. But then the question keeps going, and it wants to know, how do we treat that? So that's where we get two questions put together and in a way that you can look at that. All right, so speaking of some simple questions, let's go back through and cover our priming questions and get you the answers to those if you didn't pick them up as we traveled through our topic for today. Where is TSH created? Where is TSH created? That was in the anterior pituitary. What is the most common cause of hyperthyroidism? What's the most common cause of hyperthyroidism? We've talked about that a few times. Graves' disease. Exophthalmos should make you think of what diagnosis? Exophthalmos should make you think of what diagnosis? And again, that's Graves' disease. Sweet, so we wrapped up this section on thyroid. We started endocrine. We are moving right along. Great job sticking with me for today. If you haven't done so yet, definitely run on over and sign up for the email list. There's so much good information coming out there. That's really been my favorite thing for the past year is writing there and putting that stuff out there. So if you haven't signed up, go ahead and check that out. Really easy to sign up for it and really easy to hop back off of it if you're not interested, if the material doesn't help you, if you don't find it incredibly valuable. So go check that out. Definitely at www.physicianassistantexamreview.com. And good luck on your exams this week. And keep me posted as to as your progress, how you make out. Definitely, if you pass, if you fail, just let me know. I would love to participate in that with you. So, good luck this week, and I'll talk to you soon. We'll pick up with endocrinology next time.